Assalamu alaikum. I'm Dr. Parveen, and my topic is the role of the CT in the pre-TAVI assessment. These are my objective. So come to the first objective, which is how to acquire the CT data and its reconstruction. In our institute, we do the CT for the TAVI protocol in the 2 steps. The first step includes the cardiac, which is retrospective ECG synchronized, including the aortic root and the heart, followed by the non-cardiac CT, which is non-synchronized and including the whole aorta and the carotid, subclavian, and iliofemoral vasculature. The slice thickness is less than 1 in the cardiac, 1 to 1.5 millimeter for the vasculature, and the reconstruction kernel is the medium to smooth, and the post-processing we use the MPR, curve MPR, and 3D. Non-contrast CT is not recommended in the TAVI protocol, but you know that the calcium of the aortic valve correlated strongly with the severity of AS. The cardiac scan comprises these components, which is used for the landing zone and also the anchoring zone. So you go to the stepwise. First, left ventricular outflow tract. For the left ventricular outflow tract, you know LVOT is usually larger than the annulus. It is more elliptical and it is dynamic. It is measured 4 millimeter below the annulus, and you have to tell the shape of the LVOT and also the calcification. Then goes to the leaflet valve. You have to tell whether it is bicuspid or a tricuspid. You assess in the cine images, then the best systolic and the best diastolic phase. So this is an example of the tricuspid valve with calcification. You also mentioned the calcification on the leaflet. Then the aortic annulus, which is the mainstay of the cardiac CT, and it is defined by the virtual ring formed by the basal attachment of the aortic valve leaflet. And this annulus is usually non-circular. This is the smallest opening where the valve anchors. And the phase you used is where the dimension is the largest with adequate image quality. We usually use systolic phase, but in case of septal hypertrophy, where the hypertrophied basal septum protrude into the LVOT and decrease the dimension of the annulus during systole, we use the diastolic phase. In case of annulus, you have to measure the minimum diameter, maximum diameter, and the minimum diameter depend on the selection of the valve for the ballooning. And you have to measure the perimetry and the area, and also comment on the calcification. Then the coronary height. Coronary height is measured by the reference point, which is the annulus, by the vertical line at the lower end of the coronary artery. Then the sinus of Valsalva. You measured by the transverse double oblique plane at its widest dimension parallel with the annulus plane, and the cusp commissure dimension is taken and then average in axial images, and the height from the annulus to the STJ is the height of the cusp. Then sinotubular junction is again measured by the transverse double oblique plane aligned with the STJ, not parallel to the annulus, and the single dimension in millimeter is sufficient. Then the ascending aorta, again measured by the transverse double oblique plane perpendicular to the long axis of the ascending aorta, not parallel to the annulus, at the level of the greatest width or at the level of MPA, and it is also recommended if the valve size is small, like 23, then you have to measure ascending aorta from the annulus up to 35 millimeter. If the valve size is bigger, like 34, then you have to measure from the annulus up to 40 millimeter, and the single diameter in the millimeter is sufficient. Then you have to grade the calcification. Mild is when the single nodule, adherent, non-protruding is mild. Moderate is 2 or more nodules of calcification, and one of them is limited protrusion is called moderate, and the severe is when single or multiple nodule of calcification and protruding into the annulus may or may not extending into the LVOT. Then the most important thing is coplanar projection, which is actually the projection of the plane for valve implantation. The coplanar is the plane when all the cusps are at the same level with RCC, right coronary cusp, in the center. We know the fluoroscopic angulation is the ideal, but we know it is only valid if the patient chest positioned in a similar fashion on the CT table as during the procedure. So you have to mention. It helps in selecting the fluoroscopic angulation during the implantation, therefore decreasing the radiation exposure, contrast usage, and the procedural time. It is reported as LAO, RAO with cranial and the caudal angulations. This is the chart where you select the valve size according to the CT-based parameters. Then we come to the bicuspid valve. Bicuspid valve is very common in our population. About 65 to 70% of the patients who are coming for the TAVI are bicuspid. We follow the Seeger's classification. Classification O or 0 is the one with who have two cusps, and you have to define whether the cusp is anterior posterior or the right or left. Then you have an type 1, which is one commissure is fused. Type 2, when the two commissure are fused. Type 1 is further divided into type 1A, when the left and the right cusp are fused. Type 1B is when the right and the non-coronary cusp are fused. Type 1C is when the left and the non-coronary cusp are fused. Most common is type 1A. So this is the example of type 1A. This is the cine images, and you assess the behavior of the leaflet. And this is the systolic phase of the type 1A. So how the bicuspid is differ from the tricuspid valve is because the dimensions are greater in the bicuspid than the tricuspid valve. The annulus size is usually greater in the bicuspid. The supraannular geometry is elliptical, and the calcification in the bicuspid is usually asymmetrical or eccentric, and there is more conduction defect in case of the bicuspid. Coronary anomalies are more common in bicuspid. Left dominance is more common. There is a separate ostia of LAD and a left circ. Coronary ostia is usually a close proximity to the commissure, and the height of the coronary ostia are higher in the bicuspid. This is a good sign. Then the tricuspid valve aorta has a more horizontal orientation, which produce problem in implantation, and there is autopathies in case of the bicuspid. Then you have to complex shape of the aortic valve in the bicuspid and intercommissural dimension. The leaflet in the bicuspid are usually non-tubular. It may be flare or taper. And the intercommissure is narrow, non-circular, and this is the area where the valve anchor. In bicuspid, the valve anchor on the intercommissure area, while in the tricuspid, the valve anchor on the annulus. This is the intercommissure measurement at the different level. So the CT-derived predictor for the peri-procedural risk. These are the risks. The most dangerous risk is annular rupture, and it depends on the moderate to severe LVOT calcification. And if the valve selection is oversized, which is more than 20%, and the coronary occlusion and obstruction depend on the height of the coronary ostia, the narrow sinus of Valsalva, which is less than 30 millimeter, and the nodular calcification of the leaflet. Paravalvular leakage or transvalvular leakage depend on, again, on the calcification, the shape of the LVOT, and the annular eccentricity, LVOT non-tubularity, and based on the undersizing of the valve. If you use undersized valve, then AV conduction again depend on the calcification and the length of the membranous septum. It is less than 8 millimeter, it's more chances of AV conduction defect. Then a stroke depend on the atheroma of the aorta, of the aortic arch especially, and also on the leaflet calcification. And you can guess by measuring the LA, because if the LA is dilated, there's a chances of atrial fibrillation. Then you have to assess the second part is aorta and the iliofemoral vasculature. So you have to assess, scrutinize the whole aorta for stenosis, dilatation, aneurysm, dissection, intramural hematoma, and assess the access site. The most common is the femoral site, is the access site. For the femoral site, you have to mention the calcification, whether it is posterior or anterior. If it is anterior, you have to mention it that it is located on the anterior wall of the common femoral artery, because it produces difficulty in puncturing and also implantation for the closure system. And you have to mention where is the division of the common femoral artery, because you puncture on the before bifurcation of the femoral artery, common femoral artery. So you have to mention the bifurcation in relation to the head of the femur. So if you are taking the vessel size, it should be mentioned the minimum diameter, the location and extent of the calcification, the plaque, and the grading of the calcification. You have to especially mention if the calcification is circumferential or the horseshoe shape. And then look for the tortuosity and the dissection. Tortuosity doesn't produce problem. If it is associated with a small diameter and the calcification, then it become a problematic. Then you have to comment on the coronary artery, especially in the diastolic phase, but it is challenging because they are more calcified in case of aortic stenosis, and you can't control the heart rate, you can't liberally use the beta blocker, and nitroglycerin is contraindicated. So in case of coronary artery, the most important is you tell about the origin and the course of the coronary artery, means the anomalies of the coronary artery. Then you have the non-cardiac findings, a cardiac and the non-cardiac finding, not related to the root. Like if there is a thrombus in LV, then it is contraindicated for the TAVI. You can comment on the myocardium, and this is the case of protruding basal septum, extracardiac finding, especially the lungs, renal artery stenosis, and these are my references. And thank you for listening.
Parveen, thank you very much for a good presentation. I would like to ask one question: how often the patient are referred back to you after TAVI?
Actually, I am not interventionist, so the patient goes to the interventionist and then refer to me for the echo. And if the patient have valve thickening or obstruction, then they refer to me for the CT. Otherwise, patient doesn't follow me; they follow to the interventionist.
No, I am not asking you that one. I'm asking how often the interventional cardiologist refer you back after doing TAVI or
Ref-
CT? Post TAVI evaluation.
Post-TAVI, I will told you, if there is a complication, like if they have suspicion of thickening of the leaflet or degeneration of the TAVI procedure, then they refer to me. Otherwise, never.
Dr. Parveen, very nice talk.
Okay.
Have you used this hybrid method? I'm going to talk about that in my talk, but using the aortic annulus by CT and the peak gradient by Doppler.
Yes.
Have you
I-
used that?
Yes, LVOT by the CT, and they put this value to the.
That is a very popular thing
Yeah,
nowadays.
yeah.
So, how do you find and how do you compare that?
I think it's
Because
good.
the cutoff value for severity is
The-
1.2 for the hybrid.
Okay, but I found it good in difficult cases. I usually use in the difficult cases.
Right. Thank you.
Yeah, because the shape of LVOT and annulus is not good on echo, and it's basically the CT which can give you the best shape and size as well.